Thank you everyone for joining us today for our webinar, How to Make Community-Wide Data Sharing a Reality. Before we get started, as a reminder, your phone lines will be muted throughout the presentation. You can submit questions at any time during the webinar in the QA panel. A recording of this webinar will be sent out later this week. With that said, I would like to introduce you to our speaker. Lisa has over 35 years of experience in the healthcare industry. She's drawn on her legal expertise to serve as an in-house counsel for a major integrated delivery system. And she currently works as an attorney who specializes in health law, employment law, information technology, HIPAA, high-tech, and contract negotiations and drafting. And she teaches as an adjunct professor at South Texas College of Law. Lisa is a contributing author to eHealth, privacy, and security law, and her other writings include a monograph on patient confidentiality laws in the United States for the American Health Lawyers Association, the sidebar articles for privacy of health information, a report on the 2001 public interest sponsored by the AHLA, and a number of other articles and papers on HIPAA and other legal topics. She's a recognized expert on privacy and confidentiality and is a frequent speaker at healthcare, HIPAA, and legal regional and national conferences across the United States. Lisa is also a key player in the C3 initiative of the Network of Behavioral Health Providers, a project of the United Way of Greater Houston, which aims to establish a coordinated, system-wide, person-centered continuum of care that integrates medical, behavioral health, and social services while addressing the social determinants of health. And with that, I would like to turn the time over to Lisa.
Great. Thank you, Jennifer. I really appreciate it. And thank you to Ecovia for sponsoring this webinar. If we could go to the next slide, one of the things that I have done over the past probably 10 years is dealt with a lot of people who are trying to share data. And unfortunately, when they try to share data or when they communicate that's the initiative they want to at least attempt, they don't necessarily start with the correct question. Everybody wants to share data, and most everybody will agree that sharing data is a good thing, but most people think first, what are we going to share and how are we going to do it, or how are we going to share data and what are we going to do? And the bottom line answer to that in most data sharing initiatives is, what computer system are we going to use and how are we going to implement that? Based on the experience that I've had and based on the affiliation I have with the Network of Behavioral Health Providers C3 initiative, what I have found is the most important questions to address first are who and why, or vice versa. But you can't forget the rest of the questions. Who are you going to share data with? And why do you want to share that data? What benefits do you expect to obtain? And what benefits do you expect the data sharing initiative to achieve? The rest of the questions are important as well. What data elements will you share? What do you want to complete, or what do you want to achieve? And have you defined any performance measures to determine when you do get data sharing up and running, that those data sharing efforts have been worthwhile? How will you share it? Presumably, data sharing is done electronically, but today most people data share over the telephone or sometimes via email. But more importantly, if you do want to input or select a vendor with whom you're going to share data, how are you going to select that vendor and what systems will you use? Where will the system you're going to be using to share data actually be housed? And when do you want to start this data sharing initiative? And when, if ever, will it be finished? Probably the biggest question that I hear most often from anyone that thinks about data sharing in its entirety is, how much will all of this cost? Cost me? Cost my organization? Is there anybody that can fund this? Any place I can get funding? Will I have to pay to data share? All of these questions are questions that you should be answering before you actually start to share data. We talk about the who and the why first, because that's the most important. Who is critical to determining whether or not you're going to have a successful data sharing initiative or not. Potential collaborators are support service organizations, housing, transportation, other support services providers. But you also want to consider behavioral health providers, healthcare providers, and healthcare insurance plans. When I look at the data sharing initiatives that have been successful across the country, and there are not very many of them, probably the earliest data sharing initiative that pretty much started, that's grown fairly substantially, is the Camden Coalition. And that actually started because a group of doctors used to meet for coffee in the morning after they'd been to their offices or right before they went to them. And as they sat around the table thinking about what they were going to do that day, one or more of them came up with the idea of sharing data and said, wouldn't it be great if we could share data such that I could see all the records from one provider and you could see all of my records, so that we could treat patients that come to us as a collective whole. Now, all of those providers were of the same type, and data sharing initiatives aren't that way necessarily. All of the collaborators in the Camden Coalition were healthcare providers, but the Camden Coalition has grown. It now encompasses the school district and the city and a number of the hospitals from the city of Camden, as well as some of the social services organizations. However, it grew from an organization that had two people running the Camden Coalition software and data to now an organization that employs a significantly larger number of employees. I think it's as many as 50 or 100, and they have a $10 million annual budget. So the who becomes very important, defining which organizations or resources or entities or individuals you need to share data with. The why is equally important. Why are you going to share data? Is it going to make you more efficient? Are you going to see less trouble on your side of getting information that you need in order to treat or serve a client or a patient? Obviously, it's going to be very helpful to clients. That's the purpose of data sharing, at least as much as anybody can come up with. We always want to benefit the client or the patient. And yeah, maybe we are going to save a little money or reduce costs, both for the client and patient, but also for the entity. The technology is available today. Anyone, anywhere can share data. You can go buy any kind of computer system off the shelf and share data. But if you haven't defined what you want to share and why you want to do it, you're never going to know if you've made the goal. So it's important when you're thinking about why, not just thinking about why we want to do it, but how are we going to measure that we've actually developed and shared data the way that we need to do it in order to achieve those benefits that we've outlined. So when you sit down to think about who's going to participate with you, think about the information that you currently need or want from other organizations, and think about what other organizations need and want from you. What's important for me is that you have to think more on a line of an 80-20 rule. The healthcare industry has blossomed with healthcare information exchanges, but those are really connecting just healthcare providers, and they do it in a various number of ways, and they allow a various subset or portion or an entire file belonging to one patient to be shared with other organizations. But that doesn't make necessarily any sense for your community, and certainly it doesn't make sense necessarily for every patient. The 80-20 rule says 80% of a person's health can be managed and coordinated with the resources that are not medical resources, not healthcare providers. The 20% is potentially what you're going to wind up with as an average of healthcare providers. But healthcare providers are the ones that have the money, that have the drive, that have the patients they can certainly share data with. But understand that common data can be shared, but organizations should retain control over their own data, i.e. they limit what data gets shared with other organizations, even those that are in the same network as they. And be sure to include representation from solo service providers and all types of sizes and organizations. The collaboration agreement that we defined is probably the very first agreement that you'll need to have once you've decided to initiate a community-wide data sharing initiative, because you're going to establish reasonable expectations and goals and get people to agree to fulfill their part in that collaboration agreement. The good news is there's usually not a financial responsibility from anyone. It's just an agreement to collaborate. There's always a give and take relationship with others, but you want to find out who can bind your organization and, to a certain extent, if possible, define which organization is going to be responsible for operating, developing, and managing that shared data repository. Who is actually going to own the shared data? Is it going to be the provider with whom the data repository is stored, or is each individual participant going to maintain control of his or her own data? Define who will operate and manage the data. Who's going to ensure that the data has integrity? Who's going to ensure that you have compliance with security and privacy standards that are required? Define whether the database will actually replace what some of the participating partner organizations bring to the table. So for those organizations that might be paper-based, are they going to have a system now, but it's going to reside on the data repository? Identify any financial obligations and any participation obligations. If somebody comes in and says, I want to join your community-wide data sharing initiative, who gets the right to say, yes, you can join, or no, you can't? And of course, through all of this data collaboration agreement, or this collaboration agreement will help you identify some of the legal and operational obstacles that you may wind up facing as you implement this community-wide data sharing initiative. Don't forget to think about the clients and the patients. For the most part, if you're in a fairly large geographical area and you want to share data, remember that it's probably not going to be, we're going to put 100,000 people on this computer system at the same time. Instead, go through and determine what kinds of patients and kinds of conditions and service needs those patients have. Think about limiting the number of clients or patients so that you only have a small number to work with initially, and then you can go and add to that as time goes on. A lot of organizations that I've seen have tried to approach data sharing from a high cost, high utilization approach. What this means is the entities choose which clients or patients are costing them the most or using the most of their services. Unfortunately, with this kind of an approach, what you do is pretty much strip out a lot of the organizations that participate in a community-wide data sharing effort. At some point, certainly not at the very beginning, you may want to consider whether or not you're going to allow clients to actually participate in this community-wide data sharing initiative. Are you going to let clients come in and make their own appointments, or patients set up their own meetings with various organizations or schedule appointments with them? And finally, you want to think about the geographic location. If you're in a city of Houston, which is huge, you can't serve the entire population. So take a look at the providers, the participants, who are the resources who are going to participate in the sharing initiative, and find out where they are. What kind of needs do they fulfill? What kind of availability do they have? Where will clients find the most bang for their buck, if you will? Why sharing data is the most important question to ask. Is it actually better for your organization to share data? Probably. You can reduce costs. There's no need to redo services that are going to be provided by another participating organization. You may get additional information from your collaboration partners that you wouldn't necessarily achieve by just meeting with the client or patient himself or herself. And potentially, of course, there's going to be an improved quality of care, not necessarily just from your organization, but an overall improvement in quality of care to the individual client. The downsides, of course, are that in today's industry, people are disincentivized financially to share data. You don't get reimbursed for what you provide or what treatment services you offer a patient unless you actually complete those services or treatment for that particular patient. So it becomes important in the collaboration agreement to understand that you may want to refer a patient and you may want some kind of a compensation from that, but you might not be able to get it initially, not until there are some changes made to the way healthcare is delivered or care is delivered in the United States. Certainly, it's better for individual clients and patients. This goes without saying. Everybody that does a data sharing initiative winds up saying the big benefits are going to be to the individual client, to the individual patient, because they don't have to duplicate filling out forms. They don't have to take 3 blood tests because they go to 3 different providers. They don't have to go to 6 different food banks to get all of their food. And there's care coordination across all services. We're treating the entire patient, the entire client, not just focusing on what they need from a healthcare perspective. But the problems that you're going to see coming up for individual clients or patients is they may want to keep certain information confidential from other people with whom you're participating in the data sharing initiative. And there's a questionable improvement in quality of care. Again, how are you going to measure quality improvement? Unfortunately, we've done a very good job in the United States of measuring structural quality, which is how many beds do we have to have in order to serve this size location? How many nurses do we have to staff this? How many homeless encampments do we have to sponsor in order to take all the homeless? How many meals do we need to serve at each of the shelters in order to ensure that everybody gets food? All of those are structural quality measures that we can figure out and apply. Process quality measures are a little bit more difficult. And unfortunately, when we tried to do process quality in the healthcare industry, many of our physicians pushed back and said that's practicing cookbook medicine, and you can't do that. So a lot of the same things that we might do for one patient in healthcare, we can't duplicate for another patient. But the hardest one that we've not figured out yet how to define is outcomes quality. For those of you who have been to a hospital recently, you may have received a Press Ganey survey that asks you how your visit was. It never asks you on that visit whether you got better. It just asks you about your visit. Was the room you were in kept clean? Did you get seen promptly? Did you have to wait for a long period of time? But nowhere on there does it talk about whether you got better or whether you didn't. So when you're thinking about these outcomes and performance measurements, you need to develop your workflow. How are clients and patients actually going to come into the system, and how are they going to work within the system itself? Look for potential adoption of certain procedures that are done potentially by other clients or other providers that you can adopt, and then develop some outcomes and performance measures that are easily quantifiable. Another big question is the what. Most of the organizations that I talk to about data sharing usually start with, we want to share data. And I always say, well, that's really great. What do you want to share? And they say, we want to share data. And it's kind of like saying, I want to drive a car. What kind of car do you want to drive? A car. Well, there's lots of different kinds of cars out there. There's different ones every year from different manufacturers. And so it would be a lot more helpful if you're going to share data to have a little bit more specific information about what it is you want to share. In that sense, you need to identify the specific data elements. When you identify the specific data elements, look at the ones that are going to be common to all participating providers or partners in the initiative, and look at the ones that are going to be specific. And how are you going to deal with ones that you want? Are some of those specific elements going to be shared, or might they not be shared? Is it necessary? By identifying specific data elements that you plan to share, you're going to easily identify if and when you're going to hit any legal obstacles to that sharing. Specifically, HIPAA, the Health Insurance Portability and Accountability Act, the privacy and security standards that are within that law, and HITECH, the 42 CFR Part 2, which is your substance use disorder law, which keeps everything confidential unless you have consent from the individual, and of course various state laws. Once you've identified all of those kinds of obstacles and how you're going to deal with them, then you also have to think about where and by whom that data will be stored, who it will be collected by, and how it's going to be maintained and updated and managed, because all of those things are important to a successful community-wide data sharing initiative. So how are we going to do this? Are we going to use current systems at participating providers? What are the current systems? One of the things that I advocate is that you take or complete a current state inventory. Find out what your providers, what your participating providers are using. Are they paper-based? Are they electronic? And if so, what are they using? What kinds of functions within their organizations have they automated? And what processes and procedures do they go through? So if you're going to have a data sharing initiative, you want to be sure that you truly are not duplicating certain procedures or certain processes. Once you've put together a current state inventory, then you need to figure out which vendor or vendors you're going to use in order to do that community-wide data sharing initiative. And the vendor evaluation selection process needs to take place. The very first thing you might want to do is send out a request for information. Maybe only a couple of the participating providers have ever done anything with data sharing before, so they know a few of the vendors that are in the space, but not a lot of them. So you'll send out a request for information to just get a feel for who's out there and what they have to offer. In the meantime, taking your processes and procedures and the current systems that you developed as part of the current state inventory, you're going to develop functional requirements and potentially some case studies that you can put together and send out to vendors in a request for proposal, so that you're asking vendors to respond specifically to your needs and give you an idea of specifically what your costs are going to be. Once you've selected one or two or three vendors, and I would always recommend you select at least three to take a closer look at, set up demonstrations, set up references calls so that you see what you're getting. The demonstrations can be tailored. Those case studies that you put into your request for proposal of things you wanted the vendor to be able to do, have them do that at the demonstration. Call the references that the vendor gives you and find out whether or not the vendor's actually doing what they say they're doing. And once you've selected your vendor, then you enter into contract negotiations with that vendor. Now, there's another point, going back to a previous question, about who's going to enter into that contract. If you're a group of unaffiliated entities, who is going to enter into the contract with the particular vendor? Are all of you going to enter into the same contract? Because there will be a cost, and who's going to be responsible for storing what data where? Once you've got the vendor, then the best thing you can do is create the data sharing agreement. This is a little different than the collaboration agreement. The collaboration agreement says we're going to share data. The data sharing agreement says exactly what data you're going to share. Will the source provider own more data than what's shared? And if so, how will data be reconciled between that? How often are you going to share data? Will this be different depending on the provider's current system, whether it's paper-based or electronic? Who can request information or data from the database? What happens if a patient or a client needs to be terminated from the initiative because they don't want to share data anymore with anyone? And what happens if a provider wants to be added to the data or the database? How about if they want to leave the initiative? How are we going to handle that as well? So the data sharing agreement puts in a lot more of the specifics, and this is the one that is absolutely crucial before you start actually taking in clients and patients into the community-wide data sharing initiative. Next slide. So the questions that we just addressed or started to address, where is the administration of the system going to be handled? Will that come out of a single participating provider in that participating community, or will it be a separate, unique entity created by the participating providers? Is it going to be hosted by an unaffiliated third party so that data is stored somewhere other than with the actual community? And that's just administering the system. Operating it is even harder. Operating and managing it requires knowing what processes you're going to use, both operational and system related, how you're going to ensure privacy and security compliance with the various regulations and laws that are out there, what kind of reporting are you going to do, and when the vendor updates or enhances their software, their solution, how are you going to implement those updates? Figure out when you're going to start and when you're going to go live. Those are the two most important questions. Create an overall timeline of events and don't waver from it. You probably need at least one, if not more than one, project manager. Someone to administer part of the project, someone to administer just the implementation of the system, someone else to measure and monitor the processes and changes within organizations. Who's going to be and how many providers are you going to bring on? And when are they going to be added? Are you going to put all 15 of them on at the same time? Or are you going to schedule them to come in at certain times? Similarly, how many patients are you going to choose to start out with, and in what locations or what market are you going to be most prevalent? Functional requirements and case studies can be used here too. Are you going to do one process at a time, or are you going to try to solve everything with one patient at a time? And only after that's happened will you allow a second patient or a second client to come into the repository. Define what the implementation plan is from the vendor. When is the system going to be delivered? When is it going to be installed? How is it going to be implemented? Who's going to do what? Who's going to handle all the requests that the vendor is going to have of the provider organizations that they need to know in order to bring in their software? Are you going to test the network to determine that it works? Or you might not need to. Maybe you've done enough work. So what are your target live dates? And here I'm going to challenge you. It's not just to go for when you want to have a community-wide data sharing initiative. It's also important to have target live dates for your RFI. When are you going to let it out? When are you going to expect responses? For your RFP, same things. When are you going to release the RFP? When are you going to have vendors respond? When do you want to have a vendor selected? When do you want to finish implementation? And when are you going to actually go live? And of course, if you've gotten through all of this, one of the biggest questions that almost every executive is going to be asking at least once, if not many times during the progress, is how much is all of this going to cost me? How am I going to be able to budget for this? And I challenge you not to think in terms just of dollars, but rather think in terms of time and think in terms of resources as well. If you have one individual at your location that does intake and you're asking them to do intake on your own organization's current system, as well as intake on the community-wide data sharing initiative system, that's now 2 jobs. And so it's pretty important to understand that things might not get done or might not get done in time. If you've done a good job defining what your performance measurements are going to be, it should be relatively easy to justify the acquisition of or participation in a data sharing initiative by showing a return on investment. You don't have those benefits identified and outcomes measures identified, it's going to be very difficult to get any kind of reporting that you can take back to executive management and say, see, this is how it should be done. So let me talk about one of the most successful, in fact, the most successful initiative that I've been a part of, and I've probably been a part of 8 to 12 different data sharing initiatives over the past 5 years. The C3 initiative is coordinated through the network of behavioral health providers here in Houston, Texas. It's a group of about 40 different behavioral health providers, but the thing that's different about this data sharing initiative was that it was full of firsts. This was the first data sharing initiative I've ever been a part of where they devoted an entire year to doing nothing but planning to build a data sharing network. They were intent on involving a broad range of different entities so that it wasn't skewed to just healthcare providers, or it wasn't skewed to just social services organizations or behavioral health organizations. And it wasn't something that was advocated by a specific county or city so that we could gather data to manage the city or the county or the geographical area any better. In fact, during the planning process, we used all of the different entities that wanted to come into and be a part of this planning process to identify the specific data elements that they wanted to share. This was, everybody had a voice. Everyone at the table's voice was just as loud as anyone else's voice was just as loud. So it made sure that everybody had an opportunity to and did participate. Each of the different participating organizations defined what their organization might be or was willing to share, because they based it on what they were already sharing with other entities and other organizations some way other than electronic. They also assessed what each entity needed to see or access or use from other participating entities and why they needed that particular data. And they measured to determine whether or not changes would be necessary to their own internal processes, whether that was to accommodate multiple workflows or whether it was to accommodate the ability to get information electronically from one agency that they hadn't been able to get information from electronically before. And one of the key parts of this was to identify anticipated benefits and establish performance measurements so that we could go back at the end of the planning process and determine the whole process behind whether or not we'd be able to get benefits out of this. So, as Jennifer mentioned a little bit earlier, one of the first primary goal of the Network of Behavioral Health C3 initiative was to create a blueprint for a coordinated, system-wide, person-centered continuum of care that integrated medical, behavioral health, and social services data and still addressed the social determinants of health. Our second goal was to, and we determined this as we went through the planning process, identify and develop a pilot project that was focused on improving client and community outcomes, reducing service duplication, maximizing resource efficiency, and generating cost savings. These were the key critical performance measures that we identified that would allow us to determine whether or not we would be able to be successful with a community-wide data sharing initiative. Our planning process was fairly long, but it was extremely regimented and extremely well done as far as facilitation and project management. The people who were in charge of, first Dr. Marian Coleman and ultimately Andrea Usenga, those two people did a phenomenal job facilitating all the moving pieces and parts of this planning process and are now, Dr. Coleman has retired, but Andrea is now the executive director of the Network for Behavioral Health Providers and is the one coordinating the overall process of implementing this system throughout Harris County. During the planning process, one of the first things that we did was identify and establish key goals. The second thing that happened, or about the same time, was that we were gathering information to identify the necessary contracts that we needed to have in order to make this a success. And that brought us to the collaboration agreement, which everybody signed when they wanted to be a part of the pilot project, and the data sharing agreement, which we had everyone sign again once the system was identified and selected. The group of participating organizations in this process also identified the target clients and established what would make a client eligible to participate in this community-wide data sharing initiative. And we had to cut some corners here and leave out some of our stakeholders because we wanted to have a relatively broad brush, but we also wanted to be specific enough that we could make sure that all of the goals we were trying to achieve would be achievable. So in order for the client to be eligible to participate in the data sharing initiative, that client had to have a diagnosed mental health disorder. They had to have at least one social service need. Their household income had to be less than 200% of the federal poverty level. We took a look at the partner organizations and where they were located to determine what communities, what zip codes we actually wanted to target, and we made it a requirement for the clients to recognize that they would consent to share medical, behavioral health, and social service data with the participating partner organization. If a client says, no, I don't want to share, the client is not eligible to participate, at least in the pilot program of the C3. So what we went through to identify then was what data elements we were going to include and what platform we were going to run those data elements through. The operational requirements and processes that each organization would do, and whether or not there were some changes that they were going to have to go back to their own internal organizations to make. And most importantly, if this were to be successful, how we would be able to financially sustain this community-wide data sharing initiative on an ongoing basis. We then evaluated and selected the electronic platform and the committee that we used to define the pilot program, and then we defined the pilot program, both the partner organizations, the care coordinators who were going to be necessary at all levels of the initiative, the data sharing platform, and the key operational requirements, what we wanted to do through that platform. Now, a few of the statistics from this. When we were doing the information gathering portion of the planning process, we had 126 participants across 76 organizations and agencies that answered a community survey that went through a laundry list of questions. Do you want to share data? Why do you want to? What's your biggest impediment? What's your strongest need? What's your weakest problem? Where do you find that things are going to work or not work? So 126 participants gathered into and submitted data on a community service. At the same time, there were confidential interviews held with 30 health, social service, government, and academic executives across the city. Most of these executives were part of, or their organizations were part of those 76 organizations, but we also interviewed people who were not part of the folks that would participate in the community-wide data sharing initiative by virtue of getting a client in there, but they may have clients or patients that would show up at their organization and they could utilize the database that would be created through this community-wide data sharing initiative in order to serve them for their particular needs. There were 50 individuals across 5 focus groups that we specifically met to talk to and get information from clients, from consumers, from various patient groups. So we knew what people wanted to have if they had an opportunity to share data and have their care coordinated. And finally, over the course of 1 year, there were more than 35 meetings engaging more than 100 work group members. There were 5 major committees that this work was all divided up between. The steering committee, which was the one that made sure we were meeting the grant requirements, and this planning process was funded by a grant for 1 year, and we spent it all. We had a continuum development committee, a case management integration committee, the data sharing agreement, the data sharing committee, which took the lead on identifying and choosing and selecting our vendor, which was Ecovia Solutions Client Track. And finally, we had a group of people who were dedicated to do nothing but look at how we would financially sustain this initiative over time, beyond the 2-year program. We got a 2-year grant to conduct the pilot program in addition to the 1-year planning grant that we had in order to develop it. Next slide. So the legal requirements on all of this weren't a whole lot. What I tell clients all the time when they come to me and say, can you make me a contract? I always tell them, you need to tell me what you need before I can make you a contract. It's really hard for me to just make you a contract that's going to solve whatever it is you want to get. The collaboration agreement that we executed or had everybody execute was executed by the pilot partner organizations. But the meetings that we held, the open retreats, the open meetings that we held across the community, no one had to spend a nickel. They just had to come and participate. The C3 platform, the Ecovia Solutions Client Track platform that we selected after a pretty significant and rigorous request for information, request for proposal, and numerous demonstrations and references reviews. That that platform agreement was executed by the network of behavioral health providers. So the participating organizations still have no financial dollars and cents financial stake in this, nor have we determined at this point whether there will be a stake in it going forward. The Ecovia Solutions Client Track contract was executed by the network of behavioral health providers, who also is managing the implementation. As this system is being rolled out to the various pilot partner organizations, each of those organizations is participating in some way, but the network of behavioral health providers also has and is part of the process care coordinators, care coordination individuals who are ensuring that all of the clients who come into the system are actually well cared for and their system, their community information is being stored. And then the data sharing agreement was executed by each of the pilot partner organizations, and that specifically, as I mentioned before, defined what data would be provided by each provider. So let me give you a little bit of the statistics on all of this. We wrapped up our planning process in the July-August timeframe. Actually, I think the final report came out in July or at the end of June. And we had hoped to start the pilot project to admit the first client as early as September 1. We didn't make that date. In fact, again, just selecting a computer system doesn't make this happen overnight. Once you've selected the platform on which you're going to share data, even if you've defined all that other stuff we talked about before, it's still going to take some time to figure out the best way to do certain things. And so we actually launched the actual pilot project itself on September 30th. There were 12 primary care, mental health, substance use disorder, and social services providers who were part of the original pilot partner organization. To date, and this was at the end of 1 month, we had 3 of those 12 referring agencies serving 7 total clients. Doesn't sound like a whole lot, but through the process, we had defined our pilot project to have no more than 300 clients across 2 years in 2 different communities. So a total of 300 clients. You divide that by 12, I'm not very good in the math, but that's about 20 clients, 25 clients per agency per year. And that's not hard to meet. So the identified issues that we've found thus far are that these 7 clients have housing issues, transportation issues, benefits eligibility issues, dental and medical needs, but they also need food, behavioral health, and other social services that can be provided by the community. All in all, an extremely successful planning process and what I believe will be an extremely successful pilot project that will yield an extremely great template to be used as a model for other communities who decide to enter into some kind of community-wide data sharing initiative project. So if there are any questions, I'd like to leave the next 10 minutes or so available for anybody that has them.
Hello, we do actually have a question. The first one is, when you say behavioral health data, does this focus only on mental health or does it include substance use data?
It does both. Behavioral health is both the mental health, but it's also a lot of it is the substance abuse data. In our pilot project, we kind of keep them separate, but in our pilot project, we needed both mental health and behavioral health needs from a client. So it's just a mental health or just a substance abuse would not have made that client eligible to participate in the initiative.
Great. The next question is, do you have a data sharing agreement that you can share?
The answer to that question is no. I mean, I have a template that I'm happy to share with anyone, but until you've defined exactly what data you're going to share, until you've defined who's going to be in your data sharing network, until you've defined who's going to run, manage, and operate the data sharing platform, it's going to be kind of tough to do anything but hand you a document that you're going to have a lot of blank spaces in. So while I'm happy to help people, even talk to people about what they need to do in order to get data share. I mean, you can Google data sharing agreement free and probably get a whole slew of them, but that's not going to necessarily meet the specific needs your organization or your community has.
Gotcha. The next one is, did you integrate an EMR platform into the pilot, or are the PCP organizations that are participating entering info directly into Ecovia?
Okay, that's a good question. We looked at the EHRs that were installed in all of the different facilities, different participating organizations here in Houston, and none of them were the same. And so, no. And as a matter of fact, the total electronic health record, medical record, is not necessary in a community-wide data sharing network. You might need pieces of that. You might need the fact that this person is diagnosed with something, but in reality, there's so much restriction on what you can and can't share through an electronic health record or with part of the electronic health record that we found it was easier to define first what it was we wanted to share out of that record. Now, there are a number of the organizations, a number of the partner organizations are sharing data from their EHR, but they don't dump the EHR into Ecovia. There are also a number of organizations that didn't have an EHR that are going to start to use something like an EHR, and that's the care plan, if you will. And that is something they can enter directly into the Ecovia system, or they can have whatever system they have integrate and send data over to the Ecovia system. One of the other things that I do need to mention at that point is this is a consent-based system. Clients consent on initial intake and to the fact that they're going to share data. If the client does not want to share data within the pilot project, they are no longer eligible for that participation in the C3 initiative. But we have two levels of consent. The first level of consent is, are you going to share? But as soon as we get into mental health issues, where you run into the 42 CFR Part 2, you have another red flag that goes up on consent. And you have to ask the client specifically whether they want to share that particular data. That's a special requirement of the substance use disorder data. So we actually go through a two-process consent with any healthcare provider, any provider within the participating organizations that is sharing or would want to share mental health information.
Great. We have one more. We have time for one more question, and then afterwards, there's a few other questions that I'll send over to Lisa, and we'll be in communication afterwards. But the last question is, how did you manage 42 CFR Part 2 in the data sharing environment? Was it driven by client consent, and did they have to agree specifically that their substance use data could be shared? I think you kind of answered that in the previous question, but I didn't know if you
Yes.
wanted to.
Yeah, we pretty much did. That was the biggest risk. Under 42 CFR Part 2, there is no exceptions like there are under HIPAA for sharing data in a collaborative environment. Now, the SAMHSA is working on some changes to the 42 CFR Part 2. I actually submitted a comment to the Office for Civil Rights when they asked for how do we change HIPAA to address 42 CFR Part 2? And my response was, you don't change HIPAA to do that, you change CFR to do that, Part 2 to do that. So yeah, we actually go through, a client could, we haven't had this problem yet, but we anticipated that a client could come into the network, could be a part of the C3 initiative, eligible for the program, and enter, but as soon as they go to a mental health provider within the program, that client is asked again, this time specific to their mental health information, whether or not they want to share. If the client elects not to share, that does not mean the client doesn't receive the services, because the way we have our data sharing agreement and the data sharing network set up, the participating providers send data over to or enter the data directly into the Ecovia client track system. It just means that that client is no longer part of the C3 initiative, so we don't count them anymore. We can share the data that they've given us permission to share, but if they're not willing to share the mental health information with just the other C3 participating organizations, then we're not going to, then we cannot allow them to continue within the program.
Gotcha. Well, that about wraps it up. And like I said, we have one other question we'll have Lisa or Ecovia will be answering in email. And this recording will be sent out later this week to all those who registered. And we appreciate Lisa for doing it. Thank you.
Pleasure.